Hello from the Adventure Overland Show at the Stratford-upon-Avon Racecourse. It's Paul from Bush.uk. I'd like to start this video with a couple of shout-outs. First of all, a big thank you to everyone who came to my talks at the Wilderness Gathering in August. It's fantastic to see so many people there. Thanks very much for all the positive feedback. I've been invited to attend again next year, so I'll be there with a fresh load of content, workshops and talks to engage you and hopefully pique your interest. I'll also be speaking at the Bushcraft Show in 2025, so keep an eye out for further details about that coming up in the future. Secondly, big shout out to the guys at Wild Ways Bushcraft. I spent the weekend with them last weekend doing a level 2 bushcraft course, so big thanks to Craig, to Paul and to Mark for a fantastic weekend. I'm looking forward to working with those guys again in the future. One of the talks that I did at the Wilderness Gathering this year was on thermoregulation and heat related illness, and I thought I'd do that for you in this video in a slightly expanded version. It's getting a bit cooler now. It's pretty warm today. It's September, but it's important to realise that heat related illness can occur at any time of the year, even during the winter months. Humans, in common with other primates, are tropical animals. We're much more comfortable in warm climates and much better able to acclimatise to heat than to cold. Homo sapiens originated from and have lived in equatorial environments for thousands of years, but those living about 20 degrees above or below the equator need clothing and other forms of thermal protection to stay warm. Humans tolerate cold quite poorly compared to other mammals. The Arctic fox, for example, can maintain thermal balance at minus 40 degrees Celsius, whilst the temperature at which humans maintain thermal neutrality is around 25 degrees Celsius. Humans can rely on physiological responses to adapt to heat, but need behavioural strategies such as putting on clothes or building shelters in order to adapt to cold. Healthy humans with access to shade and hydration can acclimate to the heat stress of virtually any climate on the planet. Mammals and birds maintain a body temperature which is substantially higher than their surrounding environment. This is because of their ability to conserve heat produced by cells during the processes of homeostasis. Temperature regulation is therefore both a goal and a side effect of homeostasis. Warm-blooded animals maintain deep body temperature within a narrow range of about 2 to 3 degrees Celsius across a wide range of environmental temperatures. In humans, normal core temperature of around 37 degrees Celsius has a diurnal variation of only plus or minus 0.5 of a degree. Core temperature below 35 degrees Celsius defines hypothermia, and at below 30 degrees Celsius, shivering thermogenesis begins to fail and the human body becomes poikilothermic, which means it adjusts to the environmental temperature around it. Core temperature above 38 degrees Celsius is considered fever unless it's caused by exertion or exposure to heat. During sustained heavy exercise, body temperature may reach 40 degrees Celsius, but temperatures above 41 degrees Celsius are commonly associated with heat stroke, and mortality approaches 100% when core body temperature exceeds 44 degrees Celsius. So the range of body temperatures that are compatible with life are astonishingly narrow, 30 to 41 degrees Celsius. That sounds like a fairly wide range, but if we translate that into absolute temperature using the Kelvin scale, where normal deep body temperature would be 310 Kelvin, the range is only 303 to 314 Kelvin. That's a variance of only 3.5%. The dangers of heat stress occur primarily in unacclimatised individuals, the very young, the elderly, those with ill health conditions, or where restrictive clothing or heavy loads compounds heat stress, such as firefighters working in protective gear in a warm environment, or soldiers with protective body armour and heavy loads working in hot climates. We can only really understand heat stress and heat-related illness if we understand the physical basis of heat exchange. Heat transfer from and to the body obeys the second law of thermodynamics, which states that the transfer of heat from a system of higher temperature to one of lower temperature occurs at a rate which is proportional to the temperature difference between the two systems. You understand this because if you sit on a chair and then stand and feel the seat of the chair has gained heat from your body being the system of higher temperature, the chair being the system of lower temperature. Such heat transfer between two systems in direct contact with each other is called conduction. Heat transfer in moving fluids, such as gases like air and liquids like water, or between a still body and a fluid moving around it, is called convection. Most of the time, conduction and convection work together. For example, during immersion in water, heat is transferred from the body by conduction to water in contact with skin, and then by convection because the volume of water is large compared to the volume in contact with the body surface. So convection accounts for the majority of heat loss. The transfer of heat between two bodies at a distance occurs by radiation, and the second law requires that the transfer of heat across distance between two bodies of different temperatures occurs only when those bodies are in direct line of sight of one another. We understand this because when the sun dips below the horizon at sunset, we can still see light from it, but we no longer feel its radiant heat. The heat required to overcome the change in physical state when liquid is converted to vapour at constant temperature is called evaporation. Evaporation is essential to cool the body in hot environments. As sweat evaporates, it takes heat with it, so cooling the body. The evaporation of 1 gram of water at 30 degrees Celsius requires an energy of 2.43 kilojoules. This is known as the latent heat of vaporization. Evaporation is also responsible for most of the cooling of the respiratory tract when breathing cold air, and respiratory heat losses are important at high altitude and during deep diving. Metabolic heat that reaches the surface of the body must leave by convection, radiation, or evaporation from the skin. Dissipating the heat generated by muscular work is an important physiological problem, particularly in hot environments. In animals that pant, such as dogs and birds, the respiratory component is the primary cooling mechanism. In humans and other primates, however, convective losses from the skin account for most of the heat loss from the body. At high ambient temperatures, when convective heat loss is no longer possible, evaporation of sweat takes over as the only cooling mechanism. The relative contributions of panting and sweating to cooling the body vary enormously from species to species. Large tropical animals keep cool by sweating rather than panting because ultimately more heat can be dissipated from the surface of the skin. The body regulates the amount of heat that reaches the skin by regulating blood flow to skin and muscles by vasodilation and vasoconstriction. In thermal physiology, this is known as the shell and core model. At low temperatures, shell thickness is increased by vasoconstriction to the skin, skeletal muscle, and subcutaneous tissue. At high temperatures, shell thickness is decreased by vasodilation of vessels in the skin and subcutaneous tissues. If ambient temperature exceeds body temperature, the body gains heat and less sweat can evaporate. Let's talk about how humans adapt to hot environments. Heat acclimatization is accompanied by a constellation of adaptive responses that develop over a period of 1 to 3 weeks of continuous exposure to hot conditions. These responses are then maintained during the period of exposure and disappear over a period of about 3 weeks once the individual returns to cooler conditions. This is why it's pointless for athletes to travel to a warm environment months ahead of a competition. If we're going to adapt to compete in a warm environment, we need to be there immediately prior to the competition. There are 5 essential physiological features to heat acclimatisation. The first of these is rapid onset of sweating. We sweat more readily when we are acclimatised to heat. The second is production of dilute sweat. The advantage of dilute sweat is that less sodium is lost from the body. This conservation of sodium primarily involves the action of the salt-conserving adrenal hormone aldosterone on the sweat glands. The third response is an expansion of the plasma volume. The effects of fluid and electrolyte conserving hormones result in increased water and sodium retention by the kidney, increasing the extracellular fluid and plasma volume. Plasma protein concentration also increases during heat acclimatisation. This exerts an osmotic effect, further increasing the plasma volume. The fourth effect is a small increase in heart rate at any given workload once we are acclimatised to heat. And finally, an increase in body temperature during exercise. These responses appear to be primarily a consequence of the expanding plasma volume. All of these responses facilitate the ability to lose heat from the skin by evaporation and convection, and they allow the acclimatised individual to perform more work in the heat because optimal mechanisms to protect from dehydration are in place. After approximately a week of daily exercise in the heat, most individuals have adapted sufficiently to perform the same amount of exercise for the same duration as they did prior to exposure to hot conditions. There is, however, considerable individual variability in both the time course and the extent of heat acclimatisation. So let's move on to talk about heat stress. The human body can store additional heat that allows its temperature to rise about 5 degrees before irreversible cellular damage known as heat stroke occurs. This means that the safe upper limit for internal body temperature is about 41 degrees Celsius. As body temperature increases, this also becomes the maximum tolerable skin temperature, and this explains why immersion in hot water above 41 degrees Celsius, which would prevent cooling by evaporation, will eventually lead to death by hyperthermia. Because heat tolerance depends to a large extent on the absolute amount of heat gained by the body, it is difficult to predict survival time from ambient temperature alone. The amount of heat needed to raise body temperature above 41 degrees Celsius is dependent on body size, the extent of acclimatisation, and the individual's behaviour in the heat. So, for example, a 10-kilogram child may die of heat stroke if left in a hot car for as little as 15 minutes because its mass is small and its ability to keep cool by sweating is limited. The core temperature of a small child rises even faster than would be predicted by its mass relative to that of an adult, because the ratio of body surface area to volume is twice as great in the child. So whenever the temperature in the car is greater than 41 degrees C, the child is at risk of heat stroke, and the passenger compartment of a car in summer can reach 60 degrees C, even with the windows slightly open. An important factor in heat tolerance is the rate of heat gain. The more rapid the heat gain, the greater the incidence of heat stroke. In the final part of this talk then, we're going to discuss the recognition and management of heat-related illness. For practical reasons, heat-related illness is usually classified by severity, but it's important to recognise that there is considerable crossover between the features of the various clinical syndromes. Some early warning signs include heat-related edema and heat-related syncope. Heat-related edema is that puffy swelling of the hands, feet and ankles. It typically occurs during the first few days of heat exposure. It's caused by the plasma volume expansion as part of the acclimatisation process, and it's managed by spending a few days acclimatising before attempting heavy exertion. Heat-related syncope is dizziness or fainting, particularly on standing. It's caused by peripheral vasodilation as part of the cooling mechanism. It can be a risk to people with cardiovascular disease. We can avoid it by ensuring adequate but not excessive hydration and by moving around periodically to promote venous return. The clinical syndromes of heat-related illness include heat cramps, heat exhaustion and heat stroke. The mildest form of heat-related illness takes the form of heat cramps, painful muscle spasms that typically accompany physical work in the heat. They usually affect the limb or abdominal muscles. Heat cramps commonly affect unacclimatised individuals, but they may also be a feature of heat exhaustion. The pathophysiology of heat cramps may be primarily potassium loss. Treatment involves rest, moving the patient into shade, but preferably not into a vehicle, and providing oral rehydration with plain fluid or electrolyte solutions. Massage does not appear to help unless fluids are given first. In the most severe cases, such as in the collapsed athlete, there may be a role for intravenous fluids, diazepam 1 to 5 milligrams, and intravenous magnesium sulfate up to 5 grams in 1 gram or 4 millimole boluses over a period of 10 to 20 minutes, but this should only be done under expert supervision. Heat exhaustion is the next level of severity of heat-related illness. It's usually marked by headache, lassitude or general weariness, weakness, and gastrointestinal symptoms such as nausea, vomiting, and diarrhea. Both heat cramps and heat exhaustion are self-limiting and will improve with rest, cooling, and hydration. The most severe form of heat-related illness is heat stroke. This is a medical emergency that reflects a potentially lethal failure of thermoregulation. Heat stroke is often defined by a triad of symptoms that involves poor coordination, hot, dry skin, and high core temperature, or hyperpyrexia, usually greater than 41.1 degrees Celsius, and more importantly, brain temperature in excess of 40.6 degrees C. It's important to note, however, that this triad of symptoms is only present in about 50% of patients. It's much more often observed in classic heat stroke than in exertional heat stroke. In the most severe cases, the patient may present with delirium, seizures, or coma. The diagnosis can be made based on an elevated core temperature, greater than 41 degrees Celsius, and neurological impairment, and it reflects a total failure of heat regulation. Symptoms may include a weak, rapid pulse, wet or hot and dry skin, sweating is a poor indicator, hyper or hypotension, nausea and vomiting. Neurological symptoms may include confusion, agitation, ataxia or poor coordination, irrational behaviour, delirium, seizures, unresponsiveness or coma. Classic or non-exertional heat stroke results from an inability to lose heat, and it occurs most commonly in the elderly, the sedentary, people with chronic ill health conditions, and those taking certain medications such as anticholinergic, antihypertensive, diuretic and antipsychotic drugs. Classic heat stroke typically presents non-sweating with red dry skin and a normal potassium. Exertional heat stroke occurs with increased heat production and most commonly affects otherwise healthy but unacclimatised individuals. It's most common amongst men between the ages of 15 and 45, occurring during or after strenuous exercise. The patient will present sweating with hyperkalemia or hypotassium, hypocalcemia, low calcium, hypoglycemia, low sugar, rhabdomyolysis, disseminated intravascular coagulation, renal or liver failure. It's important to note that heat stroke can occur on a cool day, and it can be accompanied by shivering and cramps. It may not be recognised from the state of the peripheral circulation because profound dehydration can cause paradoxical features such as peripheral cyanosis, cold dry skin and shivering, which can be misleading. The cardinal feature that differentiates heat stroke from heat exhaustion is neurological change. Any confused patient that presents after heavy exertion or from a hot environment should have a core temperature measured as part of the initial assessment. Core temperature can be measured by rectal temperature or via an esophageal thermistor, which is the most reliable method. Treatment of heat stroke involves aggressive cooling, as well as supportive measures, including drugs to prevent seizure. Finally then, let's talk about a few preventative measures to reduce the risks of heat-related illness. Acclimatise gradually with a few days of heat exposure before attempting strenuous exercise. Stay out of the heat during the hottest part of the day. Wear suitable, light, wicking clothing and a wide-brimmed hat. Maintain adequate but not excessive hydration, as this can lead to hyponatremia or low sodium levels, which has a range of neurological sequelae of its own. The easiest way to check that one is adequately hydrated is to monitor urine colour. Apart from first thing in the morning, urine should be clear or a light straw colour and copious in volume. If possible, you can also monitor body mass. Rapid weight loss in hot environments typically reflects fluid volume losses. If you're responsible for a group, particularly if it includes children or those required to carry heavy loads or wear restrictive clothing, it's important to allow and even enforce adequate rest periods. And lastly, dry the skin periodically during exertion in hot environments. Drying permits cooling by evaporation of sweat. Thanks very much for watching. Please don't forget to like this video, and if you enjoy this sort of content, consider subscribing and turning notifications on so that you don't miss any of my future videos. I look forward to seeing you in the next one.